Hello everyone and welcome to this week's VJOncology podcast, focusing on breast cancer highlights from the 2026 ASCO annual meeting. We'll hear from 4 leading experts in breast cancer about key trial updates and what this means for clinical practice. Firstly, we have Oleg Gluz from the Evang Krakenhaus Bethesda Klinik, who presents data from a pooled analysis of the ADAPT and PlanB trials in high-risk hormone receptor-positive, HER2-negative breast cancer.
We have pooled data from 2 prospective trials in about 1,900 patients and focus this analysis in patients with recurrence score more than 25 or in patients with more than 4 positive lymph nodes. And in both trials, we have given different chemotherapy schedules for the patients. In the PlanB trial, anthracycline-containing or anthracycline-free treatment was given. In the ADAPT trial, we have given dose-dense chemotherapy with taxane followed by AC. And in the ADAPT trial, it was possible, according to investigator decision, to give treatment in the neoadjuvant or in adjuvant way. And in this analysis, we pulled the data together and have found 3 important things for clinical routine. The first one was that we have shown that the neoadjuvant and adjuvant chemotherapy resulted in the similar survival outcomes in these patients, and this is a big issue in the clinical discussions in these patients. The second point was we have observed the same outcomes regarding anthracycline-free and anthracycline-containing chemotherapy, even in patients with recurrence score more than 30. And the third thing that we have observed that longer treatment based with docetaxel based was some better compared to shorter treatment by dose-dense paclitaxel followed by AC, maybe due to the fact that we have started with mono treatment in the paclitaxel arm and given AAC in the second part of the treatment. Possibly it would be not the best way for these high-risk patients. But all 3 things are really important for the clinical routine, from Monday.
Dr. Glutz also discusses outcomes from the same pooled analysis in intermediate genomic risk patients.
Both trials have focused also on the second group of patients with intermediate to low-risk disease. In both trials, we have omitted chemotherapy in patients with recurrence score up to 11 and up to 3 positive lymph nodes. And in both trials, we have observed absolutely the similar and excellent outcome without chemotherapy in these patients. And in the ADAPT trial, also in patients with recurrence score 12 to 25 and endocrine response after short endocrine treatment of 2 to 3 weeks. Therefore, it's in the hormone receptor positive HER2-negative disease, it's a balance between the de-escalation and escalation in this treatment.
Next, Jana de Boniface of the Karolinska Institute presents results from the SENOMAC trial, a non-inferiority study examining the omission of completion axillary lymph node dissection in patients with breast cancer and sentinel lymph node macrometastases.
The SENOMAC trial randomized 2,766 patients who had a primary invasive breast cancer and 1 to 2 sentinel lymph node macrometastases to either a completion axillary lymph node dissection or its omission. And then afterwards, most patients actually received nodal radiotherapy because they were treated according to standards of care in the country where they were randomized. And there was actually 5 countries. So not only Sweden, but also Denmark, Germany, Italy, and Greece. So overall survival was the primary endpoint. And we could, after now a median follow-up time of 60 months, not show any difference in overall survival between the 2 groups. It's 93.4 in the one group, 94.4 in the other group. So the hazard ratio is below 1 in favor of omission. But of course, the confidence interval crosses 1, but it confirms the non-inferiority by far. We had a non-inferiority margin of 1.44, the upper limit of the hazard ratio, and then we actually came up with 1.17. In terms of patient-reported arm problems, we see significant and relevant differences at all time points after surgery, with the group receiving an axillary lymph node dissection reporting significantly more problems with the arm. It can be pain, it can be swelling of the arm, but also functional limitations in their daily life.
Following on, Peter Schmid from Queen Mary University of London explores findings by menopausal status from the Phase 3 lidERA trial of giredestrant versus standard of care endocrine therapy in endocrine receptor positive, HER2 negative early breast cancer.
The lidERA trial is the first phase 3 trial of an oral SERD to read out in early stage breast cancer. It is a randomized trial of giredestrant given for 5 years compared to standard of care endocrine therapy, which could be tamoxifen or the aromatase inhibitors, anastrozole, letrozole, or exemestane. Patients selected for this trial were selected by risk. It included no positive patients, but also no negative patients if they had additional risk factors, including for tumors larger than 1 centimeter, grade 3, high genomic score, or high Ki-67. For ASCO 2026, we presented updated data on the menopausal status. We have previously demonstrated with just under 3 years of follow-up that the addition, that giving giredestrant instead of standard of care endocrine therapy significantly and in a meaningful way improves the invasive disease-free survival with a hazard ratio of 0.7. We had also shown that distant recurrence-free interval was improved with a hazard ratio of 0.69. Here we have focused on menopausal status. 41% of patients in the overall trial were premenopausal, about 59% of patients were postmenopausal. In the premenopausal group, the majority of patients in the control arm received aromatase inhibitors, 2/3 of patients, about 1/3 of patients received tamoxifen. Again, 69% of those patients on tamoxifen received ovarian function suppression. It was a very small percentage of patients who had tamoxifen alone. Comparing the two groups, in the premenopausal setting, standard of care endocrine therapy or giredestrant was well balanced. Equally in the postmenopausal patients, well balanced between risk factors. But if you look at tamoxifen versus aromatase inhibitors in the premenopausal group, we saw slightly fewer patients with a higher risk features. And that makes sense clinically because clinicians would only choose tamoxifen normally in patients with a slightly more favorable prognosis. Now, if you look at the outcome for IDFS, they were consistent in the pre- and postmenopausal group. The hazard ratio for premenopausal patients was 0.65. For postmenopausal patients was 0.74. And the delta at about 3 years in the rates is about 3%. If you look at the distant recurrence-free interval, again, consistent benefit in the pre- and postmenopausal group. And we see a hazard ratio of 0.56 in the premenopausal group compared to 0.76 in the postmenopausal group. If we zoom in a little bit on the different treatments in the premenopausal group, we see a relatively similar benefit of giredestrant, regardless of whether patients received aromatase inhibitors or tamoxifen. That's really reassuring to see. If we look at the safety profile, the safety profile seemed very comparable in the premenopausal group and the postmenopausal group. The dominant side effects were joint aches and hot flushes, but we also saw that patients treated with giredestrant had fewer switches to other endocrine therapy. With standard endocrine therapy, about 10% of patients decided to switch to an alternative therapy, whereas only at about 5% of patients on giredestrant switched to an alternative endocrine therapy. Equally, fewer patients discontinued hormone therapy, about 5% of patients with giredestrant compared to 8% of patients with aromatase inhibitors. The dominant factor for changes seems to have been in this trial musculoskeletal pain, joint aches. And if you look at we zoomed in a little bit more on that. If you look at all grades, that looked relatively comparable between giredestrant and standard of care endocrine therapy. But really interesting, if you look at the discontinuation rates due to musculoskeletal pain, that was about 3 times higher with aromatase inhibitors compared to giredestrant. With giredestrant, about 1.5% of patients stopped the treatment because of musculoskeletal pain. About 5% of patients with aromatase inhibitors stopped the treatment because of musculoskeletal pain. So in summary, at ASCO, we presented updated data that patients benefit regardless of the menopausal status in terms of IDFS and in terms of distant recurrence-free survival. The safety profile is well established now both in the pre- and postmenopausal group, with advantages for giredestrant in terms of treatment discontinuations compared to standard of care endocrine therapy.
Peter Schmid also provides insight into the final analysis of the Keynote 522 trial of neoadjuvant pembrolizumab plus chemotherapy, followed by adjuvant pembrolizumab versus chemotherapy alone in high-risk, early-stage triple-negative breast cancer.
Keynote 522 trial is a pivotal study in early-stage triple-negative breast cancer. It really established pembrolizumab as the standard of care for those patients, given first together with neoadjuvant chemotherapy and then continued post-operatively as adjuvant therapy for another 6 months. The trial included patients with stage 2 and stage 3 disease. It had 2 primary endpoints, short-term readout with path-CR complete pathological response, and then the long-term endpoint with event-free survival. The chemotherapy regimen selected is what I would describe as the most effective chemotherapy regimen we have at the moment. So 12 weeks of weekly paclitaxel and carboplatin, and then 12 weeks of EC or AC chemotherapy, either with pembrolizumab or placebo all the way through, then surgery, and then continuation with pembrolizumab or placebo. Now, we have previously, a few years ago actually, that the trial met its first primary endpoint in terms of path-CR rates, improving path-CR rates significantly with the addition of pembrolizumab. Then a couple of years later, we showed for the first time that the addition of pembrolizumab improved the event-free survival rate at that time with a hazard ratio of 0.65. And then another 2 years later, we demonstrated that this led to an overall survival benefit. Now here we presented long-term follow-up data. This is the final analysis ever for KEYNOTE-522, which is important as it's such a pivotal study. The trial data obviously confirmed what we had seen before with longer follow-up. That's not surprising because most of the events in triple-negative breast cancer happen relatively early, after 2 to 3 years, maximum after 5 years. So data are now very, very stable. We demonstrated that the event-free survival rates are 0.68. That's about a 9%, just under 10% delta in the 7-year event-free survival rates. Equally for overall survival, we demonstrated a hazard ratio of 0.64. Again, very stable rates with about 8% delta. The benefits of pembrolizumab were consistent across all clinical subgroups. That's really important. So that includes node-negative patients, that includes smaller tumors. Even the smallest disease group with T2N node had a very substantial benefit. But it also includes patients regardless of the PD-L1 status. PD-L1 negative and PD-L1 positive patients derived a very comparable benefit. We also did an analysis in this trial and updated this now for the final analysis, looking at the outcome of patients depending on the response. So the data were separated by path-CR, complete pathological response, and patients who had residual disease. And really interesting, 2 observations. Patients who have residual disease have a substantially better outcome if this happened after treatment with chemotherapy and immune therapy, suggesting that pembrolizumab changes their biology. The delta was about 10% in absolute terms. That's a big difference. But equally interesting in patients who had a complete response, where we know they have a fantastic outcome, the delta is about 4% better, so a 4% lower recurrence rate for patients who had a pathological complete response after chemotherapy and pembrolizumab compared to chemotherapy alone. Now, when we previously reported those data, we saw this only event-free survival, but not yet in overall survival. Now, with long-term follow-up of nearly 8 years, we also see that there's a different outcome in overall survival in patients with a path-CR if it was achieved together with pembrolizumab. Looking at the final safety data, there are no new signals emerging. The safety of pembrolizumab in combination with chemotherapy has been well described. So in summary, the long-term and final data of KEYNOTE-522 confirm what we know. This is a pivotal study that has led to the approval of pembrolizumab in this treatment setting exactly in this way, giving neoadjuvantly and then continued after surgery, and substantially reduces the risk of recurrence by about 32%, but also improves survival by about 36%.
Finally, Erika Hamilton from the Sarah Cannon Research Institute discusses subgroup analyses from the HER2CLIMB-05 trial of tucatinib with trastuzumab and pertuzumab as maintenance therapy for HER2-positive metastatic breast cancer.
So this was the HER2CLIMB-05 presentation, and it was an update from previously presented data. And what we really updated was efficacy as well as objective response rate and duration of response in some key important subgroups. As you remember, the HER2CLIMB-05 really was looking at first-line maintenance. So once patients complete taxane with trastuzumab and pertuzumab, they're progression-free after 4 to 8 cycles of taxane, and they're dropping the taxane out. This is when they can enter this maintenance regimen. Patients are randomized to either getting HP alone, with or without endocrine therapy, depending on whether they have HR positive status, and that was left at the discretion of kind of local institutional standards, or HP in combination with tucatinib, again, also allowed to have endocrine therapy in that arm as well. Previously presented data was that progression-free survival was improved from 16.3 to 24.9 months. And so this was an absolute magnitude of benefit of 8.6 months. But new data was in the overall population, those that had evaluable scans, so baseline scan and an on-treatment scan, that the objective response rate was improved from 15.2% to 22.6% with the addition of tucatinib, as well as the duration of response for those responders was lengthened from 16.9 months to 20.9 months. We also looked at a couple of key subgroups, HR positive versus HR negative disease, patients that either had or did not have brain metastases at baseline, and patients that had de novo or recurrent metastatic disease. And what we found for the subset of patients that had HR positive disease, that progression-free survival was lengthened by 6.9 months. For those that had HR negative disease, it was lengthened by 12.3 months. And then what was really interesting is we looked at that subset of patients that had HR positive disease and looked at whether they received concurrent endocrine therapy or not. And interestingly, the majority of our patients actually did not receive endocrine therapy. The benefit, though, existed regardless of whether patients received endocrine therapy. Hazard ratio was 0.724 if they did receive, 0.658 if they did not. So benefit really persisted regardless. We did see progression-free survival be really quite a bit longer if you did receive endocrine therapy, really highlighting the importance of receiving endocrine therapy in this subgroup. And then in terms of brain metastases, about 12.4% of patients in this first-line trial had brain metastases at baseline. And we saw for those patients that had brain metastases at baseline that progression-free survival was more than doubled with the addition of tucatinib from 4.2 to 8.5 months. In the patients that did not have brain metastases, the hazard ratio actually was identical, 0.64 in favor of adding tucatinib with a 9.1 month benefit there as well. And then a similar story told regardless of de novo or recurrent disease, 16.8 up to 28.9 months or 12.7 up to 21.3 months. So really our overall takeaways was that regardless of whether patients had hormone receptor expression, regardless of whether they had brain metastases or not, or whether their metastatic disease was de novo or recurrent, that the addition of tucatinib to first-line maintenance therapy with HP benefited patients. And this really is an emerging new standard of care in the first-line maintenance space.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this episode, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology to join in the conversation and visit VJOncology.com for the latest updates in the field.